So let me tell you, today is a very exciting day for us. We have Stephen McConnell from Pennsylvania, who has spent most of his life dealing with treating a patient with a lipid abnormality, and we're lucky to have him today. So we together will talk to you with the promise that after you've gone through this talk, you will able to know what number you should know. You will know what can you do to improve your lifespan when you call one life to live. Now, so the question we're going to ask is, am I at risk for heart attack or stroke? This is an important question. And Steve, when do you think, at what age a person should be thinking like that?
Well, I like to look at lifetime risks. So the earlier you can evaluate your calculated risk, the better. That doesn't mean you wait till you're 50. If you're 20, or if you have really significant family history, I recommend getting this information as early as possible. All you need to do is ask for it.
So, Steve and audience, I can tell you the American Heart Association want every 20-year-old male, female, adult take responsibility for their life, consider their life health as their wealth, and at least have a lipid measurement every 5 to 6 years. And this is important to understand that this is the lesson we want to teach you today. So if you're listening to this talk, and if you don't know what your LDL is, you don't know what your total cholesterol is, please make a promise to yourself that you will know within 30 days. Let me ask you this. So what number would you like to see a person should know? So if I'm 20-year-old, should I know what my blood pressure is?
Absolutely, particularly today with the increasing rates of obesity, and we have people that are less than 10 years old with type 2 diabetes. That wasn't the case 30 or 40 years ago. So we need to check these things and check them early and follow up routinely.
So, so question is that how a 20-year-old who going to college, playing a soccer for an hour a day, sleeping feel healthy, and hasn't seen a doctor for last 5 years, why he should go to a doctor and say, listen, check me out.
Well, every good reason. I try to relate to that. When I was 20, I thought I was going to live forever, and I couldn't imagine having any risk of heart disease or anything. But my father, later in life, he had a heart attack. So I think if you know your family history and you get the numbers on that screen, that's going to give you most of the information you need to know, even if you're young.
So the data show that most people who have first heart attack, they have no symptoms. Almost 40% of those people. So the high blood pressure, high glucose, high cholesterol does not give you any symptoms.
Right. They're silent diseases, and you don't know they're there until quite often it's too late. That's why you need to know what these numbers look like so you can calculate how much risk you have.
So this number you need to know. If your blood pressure systolic, the top number is more than 120, you should make effort to bring it down. And you can bring it down by lifestyle change, changing your diet, and that effect can last for many, many years. Same thing, blood glucose. A lot of time people don't know what their blood sugar is. Just
Right.
checking once is enough, is it right? Once in 5 years is enough.
Right. And that gives you a baseline. If you're out of range, well, it's time to take some action with that lifestyle and maybe medication. But not knowing is the worst thing you can do.
So the cholesterol number you have shown there is the total cholesterol level, the LDL, the non-HDL, triglyceride, ApoB lipoprotein, and apoprotein Lp(a). So tell me about each of these things and why they're so important and how they affect and how the exposure of high cholesterol affect the incidence of having a heart attack or stroke.
Sure. Total cholesterol. Imagine you have a large city and you're just counting how many people are there. We don't know who's really bad, who's really good, but it gives you a sense for how many people are in that city. If you look in the second number, back it up one slide, please. There you go. LDL has been the standard for quite a while. Currently, they're moving to ApoB because LDL cholesterol is a narrow band of bad cholesterol, but there's other bad cholesterol. Then they move to non-HDL, which means you remove the good cholesterol from the total cholesterol, and what you're left with is the atherogenic cholesterol, which isn't just LDL. There's VLDL series, LP little a is hidden in there. Now, when you get to triglycerides, it's not cholesterol, but it's contributing to your atherogenesis or your heart disease risk, and it also creates a certain profile. It's usually affiliated with high glucose, prediabetes or diabetes. Now, ApoB is the gold standard. There's a lot of pressure to move to that because as the risk moves down with LDL, the lower you go, the less you get. It's curvilinear. A lot of people don't believe that, but it's just a fact. The lower you go, the less muscle you get on your risk. ApoB's linear. As you go down, every point from top to bottom removes the same amount of risk. LP(a), that's sort of one of my pet projects, if you will. I have someone very close to me. We don't have any reference point for family history, but when they had it first measured, I realized we need to do something. It took quite a while, but I finally found a way to get it down about 70%. That's the most dangerous risk factor. It runs in families. You usually have an uncle, father, brother who has a heart attack below the age of 55. And it rises in a man or male and plateaus at the age of 7 months. A woman may have it elevated, but it won't hit its peak until they lose their estrogen. So once they've gone through menopause, you need to recheck it if you already know. But every society worldwide is saying one measurement once in your lifetime. That's the most dangerous biomarker, so you do need to know it.
So, Judah, if you are on call, tell me if you go to a doctor, before you leave that office, wouldn't you want to know these numbers? And if you have the number, where you can keep those numbers with you?
Yes, sir. That's a great question. So, uh, we live in the modern age of technology, right? And being able to access this health information is simpler than it's ever been. So, we can actually, in the bottom left, we're gonna have some QR codes where you can scan to learn about the health devices that Healthwell Safe offers, as well as a download link for the Healthwell Safe app. So me personally, when I get my blood work done or anything, I have it uploaded directly to the Healthwell Safe app, and my physician can view it, remotely. I just do everything at home. So scan in the bottom left to learn about the Healthwell Safe app and the health devices that we offer.
Thank you, Judah. So why is so important that you need to know your number at age 20? So this is shown in this slide. So the advantage is if you know you have a problem, you have early start. So suppose you have a high cholesterol level, and basically nature is how long you've been exposed to that high cholesterol. It takes about 10 to 20 years or maybe 30 years to have a significant blockage which can cause a heart attack and stroke. So age 20, you can look yourself, what can you do to be healthy at age 60? Right. You can look at what you can do to be healthy at age 80 and what you can do to be healthy at age 100. And if you started early, like age 20, you have had to start from the one who started age 40. Yep. So you have 20 years ahead of the person who started 40. So the data has shown, and there is evidence, the science is that exposure to LDL correspond to the incidence of heart attack, stroke, and cardiovascular death. So let me ask you, Judah, could you help us out to show them they can go to this website, and it's American College Cardiology risk calculator, and just go ahead and calculate the risk. So let me give you a number, and you can put those numbers. So let's say the age is like a 50-year-old who has diabetes, who got high cholesterol, blood pressure is about 180 over 60, high blood pressure, high cholesterol, cholesterol of 210 over LDL of 150, and HDL of 35. So they are getting treatment for diabetes, they are getting treatment for hypertension. So you put all these data together, what we get. So Steve, read this slide for me.
Okay, 10-year, you're calculating risk across 10 years for atherosclerotic vascular disease. Event is high. And this individual, it's 58%. And in simple terms, it's like making a bet at a casino. You stand a chance 1 out of 2 of losing.
So the optimum risk at this age should be 4.9. So the risk is 10%, 10 times more that this person will have a heart attack or a stroke or death from heart attack or a stroke in next 10 years. Just incredible risk. So now you know that's your risk. Now you have a choice. You have a choice that you can change your lifestyle. And you say, if you start taking aspirin a day, you start managing your cholesterol, you control your blood pressure, and stop smoking. If you just 4 things, by doing 4 things, you can decrease your risk from 58% to 21%. And
than half.
that is in significant difference. Just think about half chance of dying within 10 years. 10 years. This is a 50-year-old man, so the chance of being 60 is half.
Right.
I mean, very high risk. So that's what we want to talk about. So learn your number, learn your risk, and this risk score is easily available to you. You go to website, it'll be available on your app, your Health Well Safe app, and you can calculate the risk every year and New Year Eve or on your birthday and see where you are, and you can make an adjustment.
Dr. Agarwal, I've got a question for you on that.
Sure.
So that's a lot of, losing weight, medication, exercise, diet. It's a lot of information to handle all at once. If I had to focus on one area first, what should I do?
So this answer of Judah viewer is here. So you have multiple risk factors. So if you suppose you have overweight, you have hypertension, and diabetes, and you're just able to control your weight or control your hypertension, control your diabetes, your risk significantly decreases. If you have 2 major factors and you're not able to do anything about it, the chance of lifetime risk of cardiovascular disease is like 40%. But if you just control 1 risk factor out of 2, then it goes down to almost 30%. And if you control all risk factor you have, it's almost like 10 to 12%.
Yes.
So just think about reward of lifestyle change, investing in your health, that turn into a wealth, health wealth. So we want you to seriously think about long-term health and what you are, where you are, and what can you do, which can directly affect you in next 10, 20, 30, 40, 50 years. So, Judah, you told me you're going to put this young lady and ask us questions. Like, can you describe, can you talk about this?
Yes,
this
sir.
person?
Yeah. So this is a friend of mine, let's say a 45-year-old female. She's extremely healthy. She exercises often. She's got a great diet. And these are the numbers that she's coming to you with today. So what is your analysis of this, Dr. Agarwal?
So, Steve, you want to go and talk about the numbers here?
Sure. Blood pressure is 135 over 80. That's not horrible, but it needs to be addressed. And she's fairly young, 45. Her BMI looks good, 26. She has normal glucose. Her blood sugar is good. Total cholesterol is 205. Good cholesterol is 46. That probably needs to come up. Triglycerides are elevated, 221. Guidelines are still stating 150. Dr. Castelli says 70, so there's room for improvement there. A lot of dietary changes can help with that. The LDL is 116. That's not horribly elevated. There are other risk factors I'd like to see, but her Framingham risk score is 10% risk of a cardiac event in the next 10 years.
So 10% chance of having heart attack or stroke within the next 10 years. She's 45, so before she get to 55, there are 10% chance that she's going to have a stroke
Right.
or heart attacks.
And this is a woman, so things change during menopause.
And she is busy working hard, playing. I mean, she's happy, she's healthy, and she just came to see us because Judah told him go and look for your numbers. All right. So what else you want to know about this patient as far as the lipids concerned?
Well, I want to know what the particle is. The particles carry the cholesterol. The cholesterol, believe it or not, is incidental. There's no damage unless it gets inside the wall of the artery. The particle's like a truck. I don't care the cargo content. I want to know how many trucks there are. Some are empty, some are full, and some are small and dense. And the best thing I came up with is if I throw a ping pong ball at a plate glass window, it'll bounce. But if I have a steel ball bearing, same size, but far more dense, and I throw it at the plate glass, it'll go through. You need to know what type of particles you have. The overall number, the most reliable number, is ApoB because it looks at every bad particle. And once you've got that, you've got more complete information.
So let's go back here. So we have LDL of 116. So you want to know the particle. There's no way I can, from what other tests you would like to see, which will help you with that?
Sure. Well, in that colony of different types of particles, there's only one that's the most dangerous. That's Lp(a). You can exercise till you're blue in the face and diet. And I like to say run 20 miles a day and only eat straw and drink water. Well, if you have Lp(a), you're still high risk. You have to measure it at least once in your lifetime, but it's going to be elevated or not. If it's not, you never need to measure it again because it's genetic and lifestyle won't affect it.
So what I want you to teach the audience, when you go to the physician and they say your blood work is good and you don't have to worry about anything, if that satisfy you, I mean, you need to know, don't let doctor go away from that. You need to know what is your VLDL, LDL, LDL. At least you need to know what is your cholesterol level is, what is cholesterol mass is, what is ApoB is, and what is total LDL mass is, all right?
Yeah, it's just like a neighborhood. Your neighbors all are different and they don't look alike. Well, the particles, some are less dangerous, some are more dangerous, some are beneficial. If you have good measurements, that's the highest level of accuracy to predict your risk.
So go ahead and summarize this difference between the particle size and number of particles.
Yes, we've known this probably for 30 or 40 years, but when they started measuring it and making it more available, the testing, they realized if you have the exact same cholesterol, but on the left you have a large particle and very few of them, that's a low-risk patient. And even though the LDL is exactly the same on the right-hand side, they have more particles and they're small and dense. They penetrate the wall of the artery more readily. In fact, the cells that join together and line the artery have a little gap. And if those particles are the type that are small and dense, they can slip through. And if you have a lot of them, it's like two rooms, one full of balloons and the other is empty. If I open the door,
So what single test, blood test, you will,
ApoB.
yes, that ApoB tell you if ApoB is normal or below normal,
Right.
you are on the left side, big particle,
Right,
right? ApoB is high, then you are in dangerous situation. So in a healthy person like this, with just plain lipid test alone is not enough. You have to ask your doctor, what is my ApoB is? And then don't tell me I ask you to do that because they may get upset with that.
Right. And just to summarize, if you have the ApoB, the other numbers have value, but it supersedes them. Now the LDL probably won't agree with it. It rarely does. The non-HDL might be close, but it's still based on what's in the particle and the total cholesterol. You need to know the particles.
So let's go over this cartoon and tell us what happens over time, like in next 10 years, 20 years, 30 years, 40 years.
Sure. The endothelium is the lining. It's a very thin layer cells. It almost looks like mosaic tiles, and they're translucent. I've actually seen them under magnification. Well, when they're healthy, they look healthy. There's no yellow streaks. The lining of the artery is not thickened. But over time, depending on your risk factors, those particles start to penetrate that lining. And when they do, you get a thickening of that lining. And then monocytes, white blood cells, are attracted because that's pathology, that's abnormal. And there's inflammatory processes, there's adhesion molecules. I won't get into the deep science, but it starts to snowball and accelerate. And eventually you'll have a significant deposit. It's kind of like a little blister inside the tube. And that is a plaque. And it develops. You don't want it to rupture. And the cholesterol quite often will harden literally and turn into crystals. And those can pierce the skin of that plaque. And the problem is when the cholesterol leaks out for whatever reason, when the plaque ruptures, the body perceives that as an injury. And how it throws a Band-Aid on it is throws clotting factors at it. You don't want that because now you got a clot and it wants to increase in diameter. And as it goes downstream, the artery narrows. Eventually it's going to lodge somewhere. And
So-
whether it's an old plaque or narrowing in the artery, if that thrombus, that clot, persists, it could cause an event, but it'll continue to do that, and it will happen everywhere in your arterial tree, everywhere where the arteries are.
So what you're saying is, if you have a good cholesterol and large particle, then you can keep your artery clean.
Right.
But if you don't take care of your cholesterol, don't take care of particles, those small particles will go into the artery wall and create problem for you.
Right.
And that may take 10 years, 20 years, 30 years.
Right, and it's an inflammatory process.
And it will not tell you anything. It will not have any symptoms, anything else. Just
Right.
boom, is a heart attack, just like that.
I read something, and forgive me if I don't have the exact number, but 20% of the people, their first sign that they have heart disease is sudden cardiac death. It's a pretty significant number. It's not 1 or 2%. I think it's 1 out of 5. Well, why would you not know it's coming and that's the first sign? Well, probably they didn't get the right information. If you get these biomarkers, you get these numbers, that'll tell you how high your risk is, or maybe you have very little risk.
So let's see the importance of knowing your LDL and knowing your ApoB. In this slide, you see if your LDL is below 130, but ApoB is below 100, that's the best. Then on the other
Right.
side, if LDL is more than 130, ApoB is more than 100, then your risk of living, risk of dying is really significant and becomes higher. So looking at this, if you have a choice between LDL and ApoB, which one number would you like to know?
Well, clearly ApoB, but let me help our audience here. Notice that LDL less than 130, they have two lines for that, same value. But when the ApoB was high, the risk was high. When the ApoB was low, it didn't matter. And the same when the LDL was elevated. If the ApoB was low, it was the same risk as the ApoB low on its own. You can't trust LDL. It's very labile. It depends on a number of things. It's largely a calculation, and it's not really a direct measure. And they do have direct LDL, but you're still measuring cargo. You're not measuring vehicles. When you measure the vehicle, it's linear. That's the bottom two lines. Your survival depends on how high the ApoB is.
So don't leave your doctor's office without knowing what is your
Right.
ApoB is.
Right.
Right?
NLP-A, yeah.
Yes. So let's see. So summarize this patient who is young, who exercised, who had no symptoms, and luckily at the request of Judah, wanted to have a risk estimated, what is her risk for heart attack.
Right.
And luckily we found that ApoB was high. So her lipid profile falls in the red zone. So ultimately this patient had choice to engage in prevention and protection
Right.
from small particles, which are abnormally high, treat now, so in next 20, 30 years, she doesn't develop heart attack or stroke or die from it.
Correct me if I'm wrong. They did later. This is the woman we saw earlier. She had high LP(a). Is that correct?
We'll talk about that
Okay.
patient next patient. Okay. So this slide is, I think, take home slide. It shows you normal values. It shows you where we want to be, and you should check your numbers and put dot where you are. And if it is orange, you need to go to green. If it is red, you need to go to orange. If it's really, really, really green, you need to go down to the light green.
Right.
All right. Judah, tell me about your friend who's 63-year-old running a big business. What happened to him?
Right. So my friend, Mr. John, the business executive, he actually had a heart attack and an angioplasty, and he's under, large workload, long hours. So not as healthy as case one. So have a look at his numbers and tell me what you think.
All right, Steve, go ahead and tell us about numbers.
Yeah, this is, for me, more interesting because it's a high-risk patient, and all the clues are there if they're measured. So he's had a non-ST elevation MI. Basically, that means it's an MI, but it didn't go through the entire wall of the ventricle of the heart. His transient ischemic attack, that's like a pre-stroke. It happened in 2020 with no sequelae. Nothing happened after that. His blood pressure looks good. His total cholesterol, it's okay. It's 205. He has normal blood glucose, good BMI. He's fit. Total cholesterol of 140. HDL's 39. That's low. Triglycerides are kind of elevated, 266. The LDL has, and I don't see the milligrams per deciliter, but it's about, let's see, 40.
LDL is 46.
Yeah.
46
Yeah, oh, I see. Thank you. It's 46. That's considered ideal, but there's something missing here. And he's on a torvastatin 80. That's probably why he's got a low LDL. And they put him on an intestinal cholesterol blocker, which is ezetimibe.
So, look at him. He looks like a very compliant patient.
Right.
Look at him. He had a heart attack. Since the heart attack, he lost significant amount of weight. His BMI is almost close to normal.
Right.
And his LDL is 46. I mean, that's what you want.
Right.
The only problem I see here is the triglyceride a little bit elevated, and that is not a big deal. You can get some kind of fish oil, and that can be taken care of. So but he asking you, listen, I'm 63-year-old. I already have a heart attack, and already have angioplasty, and I really want to make sure that I've done everything I can do to prevent another heart attack.
Right.
So what further testing you would do, which help him to determine what need to be done?
Well, let me point out that I know what I'm going to see even before I look at it. The triglycerides are high. That is a profile where you'll have a high ApoB with a nominal LDL. Now he's on 80 Lipitor with an LDL of 46. That doesn't impress me. The reason is the statins remove all the large particles and they leave the small dense ones behind, and that's what you got with the high triglycerides.
So now you
What's
ask,
the ApoB?
So we ask these more tests. ApoB is 85 milligram per deciliter.
Yep.
HDL is within normal limit.
Right.
100 milligram per deciliter. What about LP(a)?
It's 120 nanomoles. You want that less than 70. Now, some labs give you a different measurement, and we can get into that on another time, but that would be right around, divided by 2.4, that's 50 for milligrams per deciliter. If you have milligrams per deciliter, it should be less than 30. Now, when I look at those three markers, those are the more advanced, precise markers. The ApoB is not that elevated. I'd like to see it at 65. The non-HDL is at goal. That's what they say. It should be less than 130. It's 100. But the LP(a), that's why he had a heart attack. That's why he had a stent. And the statin, believe it or not, will not help. It'll lower the overall risk, but the primary risk factor with this individual is LP(a), and that's why I focus on it.
So why screen LP(a)? The LP little a is basically a genetic marker, right?
Yeah, you're born with it or not.
So you don't need to get once you get an LP little a is 20 and it is about 10 within normal limit.
Oh, if it's low, I say that's green. Don't measure it again. It's never going to go up. It's going to stay there the rest of your life.
And not only that, once you know it and it is abnormal, you can do something about it.
Yeah,
right?
that is controversial, but I'd like to say, without sounding arrogant, I know how to fix it. I can usually get it down a minimum of 50%. And with a very close relative who had very high LP-A, it came down almost 70%. And you can actually improve upon that. But when I see the response, I continue with the therapy because this is a great slide. By the way, if you look at people that lived after a heart attack or ischemic stroke, here's what you see in cardiac rehab. They're probably frightened. They're on an exercise bicycle, and they're all on a statin. So you can see the LDL elevated less than 10%. Well, they're on a statin. Well, the ApoB is 40% of these people. It hadn't been measured, or somebody probably would have treated it.
So in cardiac rehab will be the patient who either have angioplasty and a bypass surgery, or they already have a heart attack
Right.
and have angina. So if they want to prevent the further progression of the disease or prevent another heart attack, so these are the patients are doing exercise. The question here was asked, which is the most important risk factor, which is common to all these patients, right?
LP-A. If it's
So-
not elevated, it's pretty rudimentary.
So
after that.
53%, 53%, right?
Right. And the world's expert, not everybody would agree with me, but he is the world's expert. He's been measuring and treating it for over 30 years. I only have 20 years of measuring it. But you see it, family history, some male relative had a heart attack very young, a woman just around menopause or just after had a heart attack. A light bulb goes off. Have you measured LP-A? And that's the problem. Less than 1% get measured currently, although that's changing now. And if you look at the people who had an MI or aortic valve disease, which LP-A is 40% of the causes, you'll see LP-A underneath it. Well, it's very controversial, but the world's expert, in my opinion, is Dr. Sorturios Sam Zemeckis in San Diego. And he measures everybody. He said when they present to him, this is a cardiology clinic, 48% have LP-A. 48%. So let's split the difference. About half. Half of the people with heart disease or had a heart attack have LP-A, and we're barely testing 1 to 5% of them. So you have to ask for it.
So do you want to go to a doctor who want to check your LP-A, or you say, hell, this is too expensive test. Let's
Well,
forget about it.
I have some hard-edged opinions about that. I think the patient should get the information whether the provider believes in it or not, because you can treat it.
So LP-A cost is not $10, $20?
Yeah, some labs it's as low as like $13 or $20. I mean, what's your life worth?
It's a knowledge. It's knowledge. You need to know that LP-A. Now you know. You need to know what ApoB is, and then you need to know 10-year risk of you having a heart attack or stroke.
Yeah, real quickly, Zemeckis will tell you that the data that supports this is apheresis, which is like dialysis for lipids. It'll bring it down 80%, but you got to take the average between treatments, the highest level, and then after treatment.
Tell the audience what apheresis is.
It's like dialysis, only they're filtering cholesterol. They're not filtering because you have kidney disease. And if you look at apheresis data, it's quite good. And there's a lot of claims that these injectables, which are horribly expensive, lower it about 20%. But the fact is, if you use what they used 20 years ago, 30 years ago, you not only get the LP-A down, but you get the ApoB down, the triglycerides, the total cholesterol. And it's still the only medication that lowers every known lipid fraction. That's important to know. And the relative I have is on 4.5 grams, which costs about 23 cents a day. Pretty reasonable.
So let's talk about people who have
Sure,
high risk for coronary artery disease. These are the diabetic patient. And a lot of people chase their sugar,
Yeah.
bring it down.
Well, they should.
But it's not, sugar is okay. You want to control the sugar, but you leave the cholesterol high, then the risk of cardiovascular disease are not decreased. So if you're
Right.
diabetic, you should know your cholesterol. You should know your ApoB. You need to know your LP(a), and if you control that, then you get more for the buck than in controlling your sugar
Right.
and systolic blood pressure. I'm not saying you don't worry about them. You should control that, but don't forget about the cholesterol level.
The essence of that slide, back it up one, just real quick. Add up the yellow and the red. It's less than half of the green. The message here is if you control the cholesterol, you control 70% of your risk reduction. So getting all those cholesterol numbers and then getting them close to goal or ideal, you've taken away almost all of your risk. And you should still correct your blood sugar and your blood pressure. But believe it or not, the lipids quite often contribute to the high glucose, and they absolutely contribute to the blood pressure because you have a sick endothelial lining. You remove the lipids problem, and the lining gets healthier. And these other numbers are easier to manage.
So Judah, now let me ask you: did we ever able to make the case that young people should know their numbers, and that their health is their wealth? They should know. Tell me about your feeling about that, or should we keep talking about it?
Yeah, I think it's a really relevant question in a lot of young people's minds, mine included. Should I go get a test done, or even how to do it? So I think that you should address that question. Should young people, 20 to 40, be concerned about this problem?
Why not?
No, we just showed you that if you know earlier, you can start earlier.
Yeah.
And yeah.
I mentioned to Dr. Agrawal earlier, I had a lipidologist who was too scared, handed me a family. The mother was overwrought. Her 3-year-old son had had a stroke. They call it a lacunar stroke because they don't know the cause. What was Lp(a)? They had other things, but that was the dominant feature. The 7-year-old sister was almost blind from Lp(a) because it gets into the back of the retina. It does a lot of horrible stuff. You need to know Lp(a), and it taught me a lesson. It's never too soon to get those numbers.
I would like to ask another question and think about that. If you know this stuff, you know this causes problem down the road. Why won't you do that? Why don't you get you checked up at age 20?
Well,
and then not only
right.
that, after testing, why don't you store that number in your app? You have number from
Right.
everybody else. You have a
Document
bank
it.
account. You got everybody else's number. But why don't you have your real number, which is going to make the difference between death and living long?
Yeah, wealth is being healthy. Money comes and goes, but if you're not healthy, you'll never live long enough to enjoy it. And like I said to Dr. Agrawal, you can ask for the biomarkers. I can't guarantee every provider will do it for whatever reason. I won't criticize, but for less than half of a car payment, one monthly car payment, say $300. And I did this for the relative I mentioned. We got everything we needed. It's called direct-to-consumer testing, and it was pretty easy. And 5 days later, I had everything I needed, and it was just to confirm that they responded. Their LP(a) came down 70%. Her own provider wouldn't order it. So don't feel helpless. It's your body, it's your health. Empower yourself to find out what these numbers are.
And then we tell them choose a lifestyle.
Right.
If you choose a lifestyle which is dangerous, like we continue to smoke, you're going to pay the price.
Right.
And if you change that, and reward is just tremendous. So we really want you to take time, think about it, and at least for your next birthday, you should have all these numbers in your cell phone.
Right.
Tell me about this Bob Hopper. See, you really like him. This is a man who, I think, well-known, athletic, exercise, and health freak. So it's your friend, Steve. Tell me about
Right.
it.
Well, I can't say he's my friend, and I don't know if he'd go out and have a beer with me. He probably doesn't drink beer, but he had LP(a), and this is classic. There's been several celebrities that have died, and nobody checked their LP(a), and they were so young. I was like, That's a missed opportunity. This guy was lucky. He lived. Not only did he have a heart attack, but his roommate had to give him CPR because his heart had stopped, cardiac arrest. And you couldn't be in better health than this guy. I mean, he's immaculate health. He takes really good care of himself. But nobody told him he should have an LP little a measured. Well, he knows now he lived. But I hope that they've got him on correct therapy. I'm not going to belabor it, but statins, that's a red flag. They do not lower LP little a, they raise it. That's well documented. And most people that copy another publication, they all say, well, the therapy I use only lowers it 20%. That's BS. I never get less than 40%, even at low doses. And if they're able to take more, it's a vitamin at high dose. It lowers it 70%. Zemeckis even showed me some case studies. You got to know it's there, and then you got to know how to treat it. And if they don't know how to treat it, find a lipid specialist, find a lipidologist, because most of them still use that treatment, and they know how to treat it because lipidologists measure this on everyone.
So let's talk about summarize. Judith, summarize the whole talk. What was our purpose? Our purpose was that we want to tell you and us your health is your wealth, and if you don't, the sooner you take care of it, better it's going to be. So your first visit to a physician after age 20, because then you're adult, you're responsible for your own health.
Right.
You need to get this question in answer. Tell me about my LP little a. Tell me about my ApoB. Tell me about LDL. Tell me about blood pressure. Tell me about my sugar. Because all these things don't give you any symptoms.
Family history is everything because the most dangerous markers are inherited. They're not acquired from lifestyle.
So out of 100%, I would say 40%. Would you say?
Oh, yeah.
Would you agree that
Yeah.
40%?
It's a big chunk.
So if your father had a heart attack at age 60, that your chance of having a heart attack is very high if your lifestyle is same like your dad was.
Right. My dad was 81 when he had a heart attack, and we were shocked. I was just starting to learn this, and I remember he jumped rope twice a day for 30 minutes. He's kind of wiry. He wasn't overweight, but I ignored a clue. He was always eating a snack. He'd eat dinner, and a half an hour later, he wanted a cookie. Well, guess what? When I finally tested him with good biomarkers, the lipids told me he had prediabetes because he had a lot of particles. And his good cholesterol, there's species. You want the big ones. It was in low supply, even though his triglycerides were low. And I remember one of my mentors said, he's insulin resistant. Well, you told me that 6 months after the 3 stents were placed. They were in Florida for the winter, and he had open heart surgery, 5 grafts, and a valve repair. Well, then 6 months later, he got kidney disease because of all that. But
So the point is well taken. If you know in your family, like family, near family, brother, sister, father, mother, uncle, grandparents has illness, which is like a chronic genetic illness like diabetes, hypertension, coronary artery disease, then you need to really seriously think, question should we ask, how much it affect my genes, how many
Right.
genes I got from them. If they're immediate family like father, mother, it'll be almost 40%.
right,
So if they have any of the both have the same problem, then it is more than 40%.
Right.
It's about 60%.
I've seen some families where both parents had LP little a. That's pretty scary. And immediately I was like, are you going to test your children? I think you should. Because it's what they call, genetics, Mendelian randomization. It's like 2 decks of cards, mom and dad, and I throw them on the floor and pick up a hand. I don't know what cards I'm going to have in my hand, but they might be really bad or they might not be very bad. It has to be measured. But knowing the parents had it, that was a good thing. We measured them.
You know, the second point we want to make today, the asymptomatic nature of high glucose, high blood pressure, and high cholesterol. So if you wait for it to tell you, listen, you got a headache, you got a heart attack, or you got cannot walk because you short of breath, it's too late.
Right.
You need to do it early. So if you have a family member who have gone through that journey, then it's telling you that please come on, check it out.
Right. If you wait for symptoms, it's going to take a lot more effort, more medication, more work to get your risk down. But if you check early and see that you could have high risk later in life, you start doing something and then you never get the symptoms. That's the goal there, is to live healthy. And the sooner you know what your risk is, the better you'll be.
Yeah, so when you have first heart attack, I didn't know. But the second heart attack is you had a chance to avoid that. Is that right?
Right.
Yeah. And we can help you with that.
Right.
Okay, Judah.
All right. The next question is, would carotid ultrasounds be sufficient to prognose for stroke?
Good question. Go and take that.
We had two different points of view. There's no one kind of dangerous plaque. In fact, what's not largely known, and I've argued with cardiologists about it, but the literature is clear. It's these small cholesterol-rich plaques that are highly inflammatory. That's important. And they have a real thin, it's like a blister with a thin skin. Those cause most of the heart attacks, 70% of the ischemic strokes. Now, there's a lot of focus on coronary calcium scores, and that's important too, because some of the plaques have calcium. They tend to be older, they tend to stabilize. If your calcium score this year and then they check it later is the same, it's not progressing. But if the calcium score goes up, you need to do something. But you need to look at both. And a carotid is great for looking at unstable small plaques, which cause 70% of the events. And they've actually seen them disappear. In the early studies, nicotinic acid and cholesterol, they gave an indication for regressing, which means reversing the lesions. And I've actually seen some carotid studies where they were done and then followed for 3 years. And those little plaques were shrinking, and I couldn't see them after 3 years. That's just like it was in the government published literature. So it was rewarding to realize having that carotid scan. Plus, the patients don't like seeing plaque. If they're not compliant with the meds, do a carotid scan. It's non-invasive. You can have a suit on. You just loosen your collar, and you get a lot of information, because that's an artery that's got about that much skin, and it's a pretty large artery. That reflects all your arteries, because if you see the disease in the carotid, it's probably everywhere. It's in your heart. It's in your entire body, and it's a good way to see. Dr. Bale calls it event reality, and you show the scan to the patient, because it's cheap, it's non-invasive, it's quick, there's no radiation. I would say the calcium score is equally important, but get both, because now you have more information.
Let me tell you, Steve. I think I would say this: if you want to know about your artery, state of artery, and your carotid, both carotid, totally clean, no internal thickness, it's good news for you. But it doesn't rule out that your heart or your leg artery is going to be unhealthy.
Right.
So if they are clean, that is good. But if they're not clean, they have a plaque, then you have a problem. That means you have atherosclerosis, and you start working on it.
Right.
You start working on ApoB, start working on LDL, start working on LP-little.
Right. It's the risk factors that need the attention, because if you get them controlled, they're really close to normal. You can optimize them. Your risk plummets. You can get your risk 90% lower if you do everything right. It depends on where you were at the beginning, but you find out what your number is and then improve it. If you have elevated risk, look at those biomarkers and work with your provider to get them properly managed.
Okay.
All right. The next question. The next question is, what change can we make in our daily routine to decrease risk of heart attack?
Very good question. Starting, well, number one thing is know your number. That's starting from today. Know your number. And number two is the risk factor for coronary heart disease: smoking, your BMI, your diabetes, hypertension, and stress. If you live alone compared to you live with friends, that's shown the number one risk factor for atherosclerosis and living longer.
You're
People with friends, so friends are valuable, invest in them. The friends keep you alive compared to if you live alone. So these are the factors which really change the whole dynamics, how you see the world.
Right.
Do you see the world, angry world, or do you see a happy, dancing world? Do you laugh? Do you have friends? All this thing is in favor of living longer, living happily, versus being angry, being living alone, continue to smoke, do not do exercise, and have diabetes and
Right.
hypertension, and don't go and see the doctor, and don't ask for numbers. These are risk factors for coronary heart disease.
If you have Netflix, watch the Blue Zones. There's a book too, and it's really eye opening because exactly what Dr. Agarwal said. These people in Okinawa routinely live to be 100. Well, they have close friends they see every day. They drink a little alcohol. They don't overdo it. They're active. Their culture, they don't have a lot of chairs in the house because they're always getting up to do stuff. So they'll sit on the floor for 5 minutes and then go get firewood and come back. Everything they do adds up, but that social component, that's huge. Hang out with other people that you enjoy their company. Tell jokes. The social interaction will lower your stress and you'll be a happier person.
All right, we've got time for one more question. So this question is coming from Barbara in the chat. What are some natural additions to our diet or vitamin regimen that can help decrease our risk?
Very good. Steve, take that.
Wow. Well,
No, let me tell you, I not want to spend more than $30
No.
a month.
I would just say, number one, evaluate what you're eating and get rid of the carbs. Everybody knows this now. They talk about keto or whatever. Just eliminate the simple sugars and you'll already be healthier. And do some physical activity, at least go for a walk. That's critical. What you eat is reflecting what your health will be. Don't eat foods that increase inflammation. Eat foods that suppress it. They always say plant diet or increase plant intake. And protein in the form of meat or fish is not dangerous. In fact, how it was sourced and how they raised it is critically important. Not all salmon's is healthy. The wild salmon's better. A cow that gets out in the pasture and doesn't eat corn, which causes insulin resistance, it's a sweetener. They're eating grass and hay. The fat in the steak looks identical, but this one has stearic acid, which is healthy, and the other one was in a cage all day long and ate corn. It's got palmitic acid. Well, that's an example. As far as vitamins and supplements, there's many that are beneficial. I tend to target what's on their blood work. I select what will address that. But if you want to use one, and I'm going to get hits on this, but if I can say I'm right about anything, I'm right about it. Nicotinic acid, niacin. Don't fool around with it unless you're talking to somebody who has a lot of experience. But it works. It's cheap. It was the first drug to lower heart attack. Nobody wants to hear that anymore, but they call number needed to treat. What does that mean? Well, how many people you need to treat to get rid of one heart attack? It was 26. Zemeckis had that on Twitter. Well, it's 5 cents a gram, and 2 or 3 grams, that'll lower your risk. And most people nowadays won't agree with me. You talk to the grand esteemed experts in this. Most of them are 80 or 90. Some are retired. A couple are dead. But they all took it. They still take it, and they still administer it. And that's highly controversial. But everybody that thinks niacin doesn't do anything or it's dangerous, they're wrong. I usually ask them, how often have you used it? How many of your statin patients are on niacin? That's a good question to ask, because if they say, well, 1 out of 100, find somebody that does what I do. Get the good numbers and consider it, because it is highly effective, and it actually will take your kidneys back a whole stage. Very few people read the literature anymore, but when I saw that, I went, wow. I thought niacin was just for cholesterol, but they're shrinking glioblastomas, brain cancer tumors in Canada. It repairs damaged insulation around your nerve endings. There are 500 genes that absolutely require niacin in the human body. So how can it be dangerous? You need to read.
Let me simplify all this thing. So if you want to do the best you can do, the diet-wise, I recommend drug-free life.
Yes.
So you don't take supplement, you don't take anything, you eat food. Food is your medicine. So let's see. If you start from meat, fish, vegetarian, and vegan. Vegan is number one as a food, as medicine. And then you can do that, little bit meat, little bit fish, little bit vegetarian, most are vegan. So that's up to you. The second thing is anything color, green color, food, vegetable is good. Go for it.
Yep.
Avoid white. The other thing is just think like we call turmeric, which is part of the food. A lot of herbs you can take in the food and make the food. And then flaxseed, red rice, all these things should be part of the food. So you could really get into the shape where you start teaching children to eat the food as medicine and stay healthy. What do you think?
I agree.
You still want to take supplement?
Well, I make a joke, but I'm serious. When God makes something, he gets it right the first time. Not that the drug companies aren't wonderful, but I couldn't take metformin, so I took golden seal root and milk thistle. I was amazed how well it worked, and there was no side effects. And then I found out later it lowered my ApoB. It did like 20 things. Well, it's not one thing. It's a natural product. There's a lot of stuff in there. And I'm real cautious recommending statins, but in some instances, I recommend red yeast rice because it lowers Lp(a), and all the pharmaceutical statins raise it. So it's the first statin. Merck isolated one part of it and left the rest behind. So there is a lot of benefit in these natural supplements, but you need to target them. Find out your risk factors, find out your biomarkers, talk to somebody who treats patients and is open to natural therapy. Because most patients I talk to, I say, we can use this drug or we can use this natural product. You can guess which one most of them want.
So thank you for everybody joining us tonight. And what is coming next in 2 weeks? We believe that genetic material separate each of us, and everybody respond to medication differently depending upon genes. So we're going to talk about should you know about yourself before you take any medication? Should you know your genetic makeup before you take your medicine? So I think on 18th October, you will get invitation. We will expert talking about it, that knowing about your genes. So we are living in a new 21st century. We have knowledge which can be used to prevent complication,
Right.
to prevent adverse effect from the medication. So why not take advantage of that?
Right.
So we're going to talk about that.
It's a brave new world. Embrace it. Because
And meantime,
you can do.
we really want you to download the app and play with it. Get your medication list, get your doctor's list, and if you're parents, you want to help them to get things together. You can check your parents' vital sign. You can check you can be part of their care team and able to talk to them. I think together we make life better for each other.
Right.
So we believe at Health Well Safe, your health is your wealth, and we want you to take this at home. Thank you.
Thank you for joining our webinar. Be sure to follow us at Health Well Safe on all social media platforms so you can stay up to date with new healthcare technology. If you have any questions, please email us at info.healthwellsafe.com. And remember, your health is your greatest wealth, and we want to help you keep it safe.